Good evening, friends. I wish people who are not presenting and non-faculty kindly mute yourself. Warm welcome to all of you. This will be the last meeting for the year, and on behalf of all the senior faculty, we wish Happy New Year and season's greetings for the upcoming year. So we have eminent faculty here, Professor Kanna sir, Professor Rajgopal sir, Professor Andarya sir, Professor Srinivasan sir, and we have two important invited faculty, Professor Mukesh sir, I'm sorry, Arshad sir, from Narendra Modi Medical College, Ahmedabad. Both of them are kindly introduced by Professor Andarya sir. Today we have two postgraduates, Dr. Karthik Vanani from Namo Medical College, and then Dr. Bhaskaran from Madurai Medical College, Madurai. So we'll be having Dr. Karthik Vanani to present first. Faculty, kindly take over. So faculty, sir, Kanna sir and Rajgopal sir, sir, I'll be leaving around 9:10 or so, sir. Dr. Andarya sir will run the show, sir. Please go up. I'm traveling tonight, sir.
Yes, sir.
Can others mute, please? Karthik, please introduce yourself and start your presentation.
Sir, I'm not able to share my screen right
I think Bhaskaran has shared.
Bhaskaran, you have to unshare the screen, Bhaskaran. You have to log out of one system. Karthik, you can now share, Karthik.
Okay.
Good luck to you, Karthik. All the best.
Thank you.
Are you okay, Karthik?
Yes, sir. There is some.
Press F5, Karthik. You are not able to make it bigger. The right lower end, you can see one screen type. There you can press.
Slideshow.
The right. Okay, fine. You're okay.
Okay. Yes. Good evening, everyone. Myself, Dr. Karthik Varnani, third year general surgery resident from Narendra Modi Medical College and LG Hospital, Ahmedabad. I am presenting the case of soft tissue swelling of thigh under the guidance of my mentor, Dr. Hitesh Andarya, sir. I'm presenting a case of 38-year-old gentleman, Mr. X, who is resident of Ahmedabad and who is tailor by occupation. Who presented to our OPD with chief complaints of swelling in inner aspect of right thigh for 8 months and causing pains over the swelling for last 1 week. History of presenting illness is patient was relatively asymptomatic 8 months back. Then he noticed a swelling in inner aspect of right thigh, which gradually increased in the size of P at the time of noticing of the patient to the current size of tennis ball. Swelling was painless initially, but for last 7 days, it is causing continuous dull aching, non-rating type of pain with no aggravating or relieving factors. Patient is having history of trauma 12 years back with the tennis ball while playing cricket at the same site of current complaint, after which he developed swelling and underwent operation for the same. There is no history of fever. There is no history of any other swelling over the body. There is no history of discharge from the swelling. There is no history of functional impairment, loss of sensation or color changes over the limb. There is no history of weight loss, no history of cough, breathlessness, or any abdominal pain, and there is no history of any bony pains. Past history: patient is having a history of surgery 12 years back, incision and drainage as per the patient's history at the same site of current complaint following the trauma. Sutures were taken as per the patient's history and removed on post-operative day 2. There is no history of radiation exposure in the past, no comorbidities, and no non-drug allergies. Personal history, patient is on mixed diet with having normal appetite with regular bowel and bladder habits, having adequate sleep and no addictions. Patient has no significant family history. Based on my history, summary is 36-year-old gentleman presented with rapidly progressive swelling over right thigh for 8 months associated with pain for 1 week, with history of swelling following the trauma over the same site 12 years back, and underwent operative management for the same. Should I continue, sir?
Please wait, Dr. Karthik. Go to the first slide. The faculty will
Yes,
now
sir.
be able to ask questions. Professor Mokeshwar and Harshit sir, please go, sir.
Are you able to hear me?
Yes, sir.
Hello.
Yes, sir.
What? Spelling. It's in my.
Yes, sir.
Are you able to hear me?
Yes, sir. I'm able to hear you.
Right. Go to the next one. Go to the next slide. Inner aspect for the 8 months and pain or the swelling. Yes, next one. No, wait. Go to the previous slide. From this history, what do you think could the swelling be? I think my net connection is poor. I have to change over. Is there anybody to take over? I'll change my net connection, sir. Shanai, sir, please. My net is good evening, Shanai, sir. Good evening.
Yes, sir.
Yeah, I'm Dr. Rajgopal Shanai. Just quickly to go to the second slide. Yeah, just second slide. Yeah. So this is for your checklist, but you can always, as a PG, you can write that full sentence. So 38-year-old male, resident of Ahmedabad, tailor by occupation, presented the hospital with following complaints. Okay, right?
Okay.
Go to the next slide. Yeah. So that's fine. Now, this is what are your 2 complaints. So that means to say from the time of 8 months duration till today. That's what is the events form.
Yes, sir.
Whatever you can call it as history of present illness, right? Okay, next slide. So now, if you look at this carefully, this slide, your third whatever arrow mark or bullet, that was not required at this here. Okay. You understood that?
Yes.
What I'm trying to tell is anything which you think the sequence of events which have happened continuously, then only it becomes significant. Somebody had a trauma, leg is the common site of a trauma, whether it's a cricket ball, tennis ball, this ball, that ball, whatever it is. So this is not required at this stage because totally patient was asymptomatic, correct?
Yes.
Correct? Yeah. So in other words, yeah, just go to the same slide, go back that 4, slide number 4. Yeah. So that's what it is. Then you have written that, yes, in our side, we nowadays stop teaching for PGs, peanut and tennis ball and watermelon, etc. all those size. Today we accept, small size about a centimeter or so. Everyone knows, even if your patient is like this size, that's accepted. All right. There's no.
Yes,
so it's small inside. The only thing we would like to answer this question here. What do you think the growth? Is it a rapid growth from peanut to tennis ball? So Tennis ball, which tennis
Yes,
ball size approximately, roughly? So
roughly 7 to 8 centimeters.
So what I'm trying to tell is, so in other words, for the duration of 8 months, that means there is a growth. This is what we would like to know. Correct?
Yes, sir.
Why this question important for a tailor? For a tailor. Now come back to your profession, tailor. Medial side of the thigh, correct? No, don't show that slide. Go to slide number 4 only. Yeah.
Okay.
He's a tailor, correct?
Yes, sir.
So why I asked this question? Tailor, no?
Is it
What do they do? Tailors, yes.
during
Which muscles? No, which are the muscles which they normally use? No, tailoring.
flexor extensor of thigh?
So what are those? Do you know tailor's muscle and all those? So do you know? No idea.
No, no, sir.
Do they put serratus? I'm sorry, the sartorius.
Yes, sir.
So-
Palating muscle, sartorius.
So you know the flexion, extension, abduction, adduction, out of which are the muscles put into action here. So whether there is any, not that this patient has developed or something. So any injury, small hematoma formation, and then we would like to know over a period of 7 months. So what do you think? If there's a hematoma in the thigh, do you think it will persist like this for 7 months, 8 months?
No, sir. If there is a hematoma, over this period of time, will get infected, secondary infection, and patient will have pain, tenderness, and patient might have fever.
So either it may get infected or you can probably resolve, correct? It can resolve itself.
Yes, sir.
So any other complication can happen. Sometimes blunt trauma even give rise to some kind of a pseudoaneurysm formations, etc. What is pseudoaneurysm means? Sorry, pseudoaneurysm. You said, some blood clot and other things. You mentioned that is hematoma. Yes.
Yes.
Yes. So it's possible that a small injury can happen and some blood clot can accumulate over that, and it may even get sealed off, but with a clot formation, almost mimicking a pulsatile swelling. Can you hear me?
Yes, sir.
So what I'm trying to tell is, so this is few things you should keep it in mind. I'm not trying to say your case is a hematoma or something like that. So patient noticed a swelling on the inner aspect of the thigh for the last 7 to 8 months duration. It is progressive. The word here is progressive. Progression, yes. 1 centimeter according to has reached about 7 centimeter size. Okay.
Yes, sir.
So here that trauma of 12 years should not be written now. Okay. Right. It has to be shifted in the past history.
Past history.
Yeah. Apart from this swelling, whichever you are talking about, immediate next question is not about the pain. You are written there, it is painless, and for the 7 days, continuous dull aching pain. So what is the cause of the dull aching pain?
If we think in terms of tumor, soft tissue tumor, due to rapid progressive increase in the size of the tumor, there might be stretching of the pseudocapsule.
Stretching of the pseudocapsule, or maybe within the any compartment. Tumor. Yes, when anything is growing. Yes, please go ahead. Yes.
Tumor outgrows its blood supply, causing subsequent necrosis, or tumor may infiltrate the adjoining neurovascular bundle.
Yeah, that of
causing so.
You are written there no radiating pain, right? So yes, what do you mean by aggravating relieving factor for this pain in your case, in your patient? What specific question you asked for aggravating?
I asked if the pain increases or decreases with a certain position, as if the person is individual is resting, and if pain is remaining the same or decreasing on
I'm-
walking for
Yes.
some duration, the
Movement.
pain is, yes, the pain
He's a
is,
tailor. No, he's a tailor. Correct.
yeah,
So
yes,
would
sir.
like to know which muscles, when he's contracting, what type of pain he's getting, right? So this
Yes,
is
sir.
what you should know. One is walking, another is movements. Movements.
Moments, yes, sir.
Is he able to do his tailoring activity? See, every case is different. That is what we tell you. Is that the reason why he came to the hospital? Because it's affecting his occupation.
Oh,
Is it clear?
yes, sir.
If you talk in that way, it gives you more weightage. You understand? Huh?
Yes, sir.
Okay. No history of fever and anything else. Next, go to the 5 before somebody else take over. Yes, just I'll. Now, before you go to all this other swellings and all that things which you have asked, first is always local features. Local means loco-regional, whatever. One is about the increase in the size of the swelling. Second thing about the pain, which you have already mentioned.
Okay.
Right?
Yes.
Third thing about the fever you have mentioned. Why did you ask the fever?
I asked asked for the fever to rule out secondary infection, as a patient is in pain for the last 7 days only.
I will
So
ask only one important question. Is this secondary infection in a soft tissue tumors or this 8 months duration? I will quickly ask you the question. Does lipoma get infected? Straightforward question.
no, sir.
Why not? Simple question.
But
Very simple question. Why
it is capsulated.
Okay, I will ask you another question. Simple way. Does branchial cyst gets infected? It has also got a nice capsule, yeah. Branchial cyst.
Yeah.
Does it get infected? Yes.
Yes.
Because it has got rich lymphatics. Lipoma doesn't get infected because it's relatively avascular. There's hardly.
Avascular. Okay.
So what I'm trying to tell is these sort of soft tissues which are growing like this, fever is not, but you can always ask, but you should always try to say why you are asking all these questions. All right. So any pedal edema has he noticed? This next question you have to ask. Any unilateral limb edema?
No, patient is not having any limb edema.
Why that question?
If the swelling is involving lymphatics or any venous cause, it may cause distal limb edema.
So neurovascular.
Neovascular involvement. Yeah.
Since you mentioned somewhere that pain radiating and nerve related question you had asked on previous slide. So it's nice that you asked. Patient has not noticed any edema of the leg. So no other functional impairment that you have already written about those. To that extent of color changes and all may not be really required. By the time acute ischemia came in, they would have got really severe pain. All right. So that's all other things you have written there. Somebody else can take over, sir. Just this slide, keep this slide on, but.
Okay.
Hello? Anyone is there? Sir,
Anna sir, you are not audible, sir.
Sir, good. Sir, nice to see you, sir. Sir,
Anna sir, we are not able to hear you, sir.
No, sir.
Maybe you log out and log in, sir. We are able to see you, sir. Are you using any headset or something, sir?
I think. So till Dr. Khanna sir ask you one or two, I think I'll finish off this question. What
Yes,
did
sir,
you
yes,
find when you asked this no history of other swellings?
To rule out any syndromes, as in case of in certain syndromes, there are multiple swellings present over the body. such as in case of leaf-ramenue neurofibromatosis.
What do you,
Uh,
what did leave from it? What did you tell? Leave from it.
Yes, sir. Multiple swellings.
No. What did you tell? Leaf reminiscence syndrome? What? Von Reckling-Acids. Don't get
Von
confused.
Reckling, neurofibromatosis type 1, von Reckling-Gausen syndrome, leaf-ramenue syndrome.
Mainly, we are talking about multiple skin rashes, those K-fillet spots, and patients who are having these neural tumors, right?
Yes, sir.
So you can also have what? Uncommon, multiple lipomas.
Lipomas. Yes.
But so thigh is one of the sites of a slow-growing neoplasms, right? So whichever it is, whether it's a lipoma or neural tumor. So that's what you have written. What is the loss of this hearing functional impairment and all you have written there?
To check any neurovascular involvement if the nerves or vessels are involved causing functional impairment.
Okay, other questions? Weight loss, cough, abdominal pain.
To rule out any metastasis as soft tissue sarcoma, soft tissue tumor are more likely to have lung and liver metastasis. To rule out that, I've taken the history of cough or any breathlessness or abdominal pain.
So at the end of this relevant history, whatever you have taken, what are the things which you keep it in mind?
There is a sudden increase in a progressive increase in the size of the swelling. That's first thing. The swelling is causing pain since last 7 days. So that I will keep in mind, and history of trauma. These three things. Sir.
So your answer should be a soft tissue swelling. So soft tissue swelling, since it is progressive, I would like to consider soft tissue tumor.
Yes.
And about the types and all, probably we will ask you later. And whether it is having significant pain, which is disturbing his routine activity. This is important at this stage. The reason why you are further proceeding. Okay.
Okay.
Dr. Hitesh sir, these are our few questions at this stage from my side.
Yes, sir. Yes, sir. Khanna sir, are you there? Srinivas sir. Dr. Mukesh, Dr. Akash. Any question at this level from your side?
Hello.
Yes, sir. You are audible now. Yes, sir.
I'm audible now?
Yes, sir. Yes, sir.
Yes, sir.
Yeah, Karthik, I was asking that if a football player or a cricket player is there, yes, and he develops a swelling exactly in the same area.
Yes.
What is one diagnosis?
Hematoma, sir. So most.
Yeah, hematoma is okay. Yeah. After that?
Bursitis, sir?
No, not in the bursitis there. Have you heard of any rupture of any tendon there?
No, sir, I'm not aware of that.
Okay, rupture of the adductor longus, which is there. And that is very typical that a patient who is a football player or cricket player, he develops all of a sudden pain almost in the mid of the thigh on the medial side. And then you will find there's a lump, especially when he is doing the adduction movement. And that is very typical of a rupture of the adductor longus. In fact, in this week only, we have operated one case of the rupture of the adductor longus. So that is also one of the things you should keep in mind. Okay.
Okay, sir.
You think that this is a case of a vascular malformation?
No, sir, because on examination there is
no from exam. Up till now, history, what you have taken?
History, yeah. We are still on the history. Because we have just seen the picture of that, you know. So based on that, I'm asking you that, are you thinking of a vascular malformation there?
Mm, No, sir.
Can it be there? Yes or no?
Yes, I'm not sure, sir.
Okay. No, just based on the history, tell your differential diagnosis.
The first diagnosis is soft tissue swelling, most likely soft tissue tumor, uh, uh, chronic hematoma.
Now, in the soft tissue tumor, what are your differential diagnosis based on only history?
Based on history, the soft tissue involving the fibrous tissue, fibrohistiocytic tumor, more likely.
It may be benign or it may be malignant. No,
Malignant, yes.
benign or it can be malignant.
More likely malignant, as the patient is complaining of pain recently.
But
So,
which benign tumors are very painful? Which benign tumors can be very painful?
angiolipomas or lipomas involving the nerves, neurolipoma.
You know what is that disease called as when it is very painful, multiple lipomas are there?
Yes, sir. I'm not able to recall it right now.
Derkham's disease, you know?
Derkham's disease, yes, sir.
That's called Derkham's disease. You know? Right. Then neurofibromas can be very painful. You know? So
Yes.
even the benign tumors can also be painful. Okay, apart from that, what else can you think?
As the swelling is very close to knee joint, bursitis, because the profession is tailor, so it has lots of knee movement during the tailoring work, so there might be bursitis.
That is one. Okay, vascular malformation. I am giving the hint of that. It can be
Yeah,
vascular. Can it be a inflammatory swelling?
yes, sir. It can be inflammatory swelling,
Like
but such long history, it is unlikely.
which inflammatory swelling can present like this? A long history may be there.
I don't know.
No, chronic abscess, no? Any chronic
Okay,
abscess
sir.
there or the tubercular abscess is there. No, they can present very long history may be there. It may be there for a very long. So all these are the differences. So one should not always go with one diagnosis that it's a case of a soft tissue sarcoma you are dealing. But all these differential diagnosis has to be kept from the beginning there. Okay, I think you can go on the
Okay, sir.
examination. Yeah.
General examination of the patient. I will examine my patient with adequate exposure with the consent in well-lit room. Patient is moderately built and nourished. Patient is conscious, cooperative, well-oriented to time, place, and person. Performance grade, ECOG grade is 0. Patient's height is 165 centimeter, weight of 55 kilogram, with BMI of 20.2. Temperature is normal palpation method. Pulse of 80 per minute in right radial artery with regular rhythm and normal volume. Blood pressure of 124 by 76 millimeter of mercury in the right brachial artery with by auscultatory method in supine position. Respiratory rate of 16 per minute. There is no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or edema. These are the clinical picture. On local examination of bilateral lower limbs, on inspection, the gait is normal. There is no limb length discrepancy. Left lower limb appears normal on inspection. On inspection of right lower limb, a single vertically overt swelling of size approximately 6 by 5 centimeter is present over the posteromedial aspect of right thigh. The upper margin is 25 centimeter below the inguinal crease, and the lower margin is 7 centimeter above the knee joint. The scar of secondary healing is present over the swelling extending vertically upwards 3 centimeter beyond the superior border of the swelling and inferiorly 1 centimeter beyond the inferior border of swelling. The borders are well defined. There is uneven surface. There is no visible dilated veins or sinuses, no visible pulsations. Hip and knee joint movements are normal. There is no edema and no visible inguinal swelling. On palpation, left lower limb examination is normal. On examination of right lower limb by palpation, the temperature is normal. Mild tenderness is present over the swelling. A single vertically overt swelling of size 7 by 5 by 4 centimeters is present over the posterior medial aspect of right thigh. Upper border is 27 centimeter below the pubic tubercle. The lower border is 12 centimeter above the medial epicondyle of tibia. The consistency is variable, soft to firm consistency. The swelling is non-fluctuant, restricted movement side to side and along the long axis of taut muscle. Skin over the swelling is not pinchable. There is no palpable pulses over the swelling. Distal pulses are normal. There is no sensory motor deficit and no palpable inguinal lymphadenopathy. Systemic examination on respiratory examination, bilateral air entry is present. No abdominal sounds are heard on auscultation. Cardiovascular examination as soon as to heard. Central nervous system examination, there is no focal neurological deficit. On per abdomen examination, abdomen is soft with no palpable organomegaly. There is no bone irregularity felt over spine, skull, or ribs. On basis of history and my clinical examination, the summary is 38-year-old male patient presented with complaint of rapidly progressive swelling over the inner aspect of right thigh for 8 months, causing pain for 7 days with history of trauma and operation for secondary operation with secondary healing at the same site. On examination, well-defined vertically overt swelling of 7 by 5 by 4 centimeter is present over the posterior aspect of lower third of right thigh with some mild tenderness and variable consistency, having restricted movements with no palpable lymph nodes and neurovascular deficit. Other system examination is unremarkable.
Karthik, just 1 minute, just hold on before you go there. Go to that picture, please. Since it is in the limb, probably we can show the picture for 1 or 2 minutes. Okay, is it possible to get one small close-up of that? Close-up of this one of them? You can probably, you could have cut that genitalia region, and you could have straight away scroll and just lift, just push it up.
You can zoom it, Karthik, if possible, you can zoom it.
He can, sir. It is in that, they have that PowerPoint. We can see, you are not told the most important thing here is the plane of the swelling. See, there is no mention at all. That's the reason so no. Okay, yeah, that's what I'm trying to tell. There's partly genitalia seen. Please shift it up. Don't show that area. Just cut that, no, from above. Yes,
Okay.
correct. Come down. Correct. What? Okay. Enough. Okay, a little blurring, but doesn't matter. Okay. Okay, now I think you just go to that, what is that, where we started, inspection slide or something. So when you start the inspection of this, yes, definitely you can mention swelling. But then since you already mentioned about the earlier incision, it is nice to tell, the scar. So scar. Okay. So whether the scar healing was, you are written the second healing, etc. Why did you mention from the 25 centimeter below the inguinal crease? It's not really required to that level. Why quite far away? Tomorrow, if there's a below the knee, some swelling is there, you don't have to say like that. Just you have got a knee joint, no?
Okay.
Arbitrary you can divide,
Yes,
upper, middle, lower. So you can always tell in relation to the knee joint, obviously because it is the lower part, correct? But you can't say you are wrong also. But it's better that don't go too far away like that. So now the next important thing is, do you feel it's well-defined borders on inspection? You have mentioned about the surface. What is the surface? Surface.
Surface is uneven, sir.
See, again, technically there could be some difference of description, but irregular, irregular surface, nodular surface, smooth surface. Uneven, I understand as what? According to what do you mean by uneven? Uneven surface. What do you mean? Yes. It is not smooth. Is that you want to say?
Surface is not smooth. Yes, sir.
So you can say bossylated or
Nodular.
like that.
Okay. Did you mention about the shininess in the center and something pointing like thing there? I'm not sure. Probably Dr. Hitesh sir can. Something is there, pointing like thing. If this picture is seen, I don't know.
I think that
It's
yes,
flesh, sir.
some flash is there on the
Flesh.
So for me, at least what you should have mentioned is the first is the scar, second is there is more pigmentation there over the swelling, correct? Look at his thigh skin. Yeah.
Yes, sir.
Where are you? Yeah. Look at that.
Yes.
There is pigmentation, discoloration,
Yes.
all the reaction of the
Yes.
skin because of the delayed healing. You understand?
Delayed
Delayed
healing.
healing. Some of the abdominal incisional hernias and all, when you operate, you'll find this kind of a picture. You know that? Thinning of the skin and a continuous healing by secondary intention. You can see those scar marks also.
Secondary. Yes.
Skin is pigmented and surface. Okay, I will take it because since we can't really appreciate. Borders, yes, upper, inferior, and all. Medially, I think not very clear. And surrounding skin, you should also give a mention. Surface, border, skin over the swelling, then surrounding dilated veins you have mentioned, right? And limb above always and limb below.
Yes.
Limb above, limb below, right? Accordingly, distal. Distal means the whatever you have swelling and below there. So there is no edema. Everything is normal, right? Sir, I think he got disconnected. I don't know.
I think so. No, he's there. Share your screen. Share your screen, Karthik, again.
Yes, sir.
Yes, sir.
Yes.
And again, what Shinoy sir has told is absolutely an observation finding of a good observer. We don't require even to become an MBBS for that, right? So these are the things which layman can notice, that there is difference in color. There is this set of kind of surface like that. Just a suggestion, no criticism.
Spend these are simple things, sir. Spend some time. You will get more credit, sir, if you do not miss the findings. Okay?
Okay.
Because size and shape, most of you know very well with the ultrasound findings. 1 centimeter, 7 centimeter, all that thing. Correct? Yes.
Yes.
Can we go to the next slide where you are now? Next slide, palpation was. Yeah, just hold on to that. Go back. One slide, you go back. Yeah, okay. So, yeah, that's fine. Hip and knee joints, again, you are written there. No edema, no visible inguinal swelling. Refers to what?
There is no lymph node enlargement. No lymph node involvement.
So, proximally, more importantly, if there is this swelling, if you think, why did I ask that vein? Because for me, it looks very superficial. And what vein comes there?
Or this
is a medial side.
grades of enhancement.
So what would I have expected in the thigh?
Lymph node
Yes.
Superficial inguinal lymph node enlargement.
No. In relation to vein.
I'm not able to understand, sir.
What I'm trying to tell is, this is a case of if this is swelling has compressed the vein.
Yes, sir.
Where you would have got the varicosity. That's what I wanted.
Distally, sir.
So that's what I would like to know.
Okay.
Distally varicosity and edema.
Edema, sir. Yes, sir.
That is
Edema, sir. Distal.
area where the long saphenous vein ascends, correct?
Yes, sir.
So this is the point which I would like to mention here. Always see carefully both above as well as below onto the side. No visible pulsation. I think we asked why this no sinuses. What is that you have in mind?
Sir, abscess, chronic abscess.
Already, Dr. Thalas sir already mentioned in the initial part, the trauma, then swelling, chronic abscess,
Yes.
tuberculosis, multiple sinuses. So it's possible, with the chronic infections. So
Yes, sir.
sinuses, osteomyelitis, all those things are. So keeping that in mind, you have mentioned about no sinuses, no dilated veins. So mention also. Just can you name some benign swellings with some dilated veins and some malignant swellings with the dilated veins? Some swellings. Can you hear me?
Yes, sir. Yes, sir.
Can you tell me some malignant swellings with dilated veins over the surface? You have to tell little quickly, either you know or you
Okay,
don't.
sir. I'm not aware, sir.
To sarcomas known for dilated veins, synovial sarcoma and all this. In the breast, do you know any condition? This you should know, breast.
Yes, sir.
These are the spot diagnoses, no? When you find a large breast with a dilated veins. Heard of Phyllodes tumor? Okay, we
Yes,
can
sir. Phyllodes.
go on like that. I think need a little more details that you need to know. So highly vascular tumors, always the indication of a big veins over the surface.
Sir.
I'll just only one question related to that. Suppose you find a lot of veins over the thyroid swelling. What do you think you keep it in mind? Thyroid, big veins.
So
Thyroid swelling,
thyroid. Okay.
veins. Yes. No. So okay.
No, sir, not aware.
Lower border is not seen.
A retrosternal involvement.
I think yes. Somebody can take over, sir. Thank you.
Karthik, how did you say the 3 dimensions of the swelling? You said 7 by 4 by 4 centimeters, isn't it?
Yes, sir.
So how did you measure that 3 dimensions of the swelling?
Sir, on palpation using measure tape and lifting the swelling. As swelling was liftable, I added the third dimension on palpation.
Do you think it's a pedunculated swelling where you can have the 3rd dimension? Or
No,
is
sir.
it sterile swelling?
It is non-pedunculated swelling, sir.
Yeah, so if it is a non-pedunculated swelling, you are not able to lift up the swelling from that area, then probably you cannot go for the 3rd dimension. No?
Yes.
So it's better to just say it is 7 by 5 centimeters in size.
Yes.
Okay.
And did you mention the skin fixity of this swelling?
Yeah.
It fixed to the
Yes,
skin?
sir. Yes, sir. The skin or the swelling is not pinchable.
Okay.
So it, yes, fixed to skin.
And as Dr. Shenoy was saying that there is something shining in the central part of that. If that something shining is there in the central part, then what is your diagnosis?
Then it would most likely be abscess.
Which abscess? Shining thing in the central part of the swelling. Any cystic swelling?
Well,
Any cystic swelling? Hmm? How do you make a diagnosis? Cyst or sebaceous cyst?
Yes, sir. There will be a punctum or the skin,
Yeah, there will be punctum will be there.
and the consistency will be, the swelling will be fluctuant.
And you won't be able to pinch up the
Cystic
skin there.
skin will be not pinchable.
Yeah, these are the two most important things. That you see a punctum in the central part and you are not able to pinch up the skin. So both the things are there in your swelling there.
Yes.
So you should keep your mind open about that. You know? That's what I'm saying that. Did you check for the popliteal nodes here?
No, sir, I didn't check for popliteal.
Should also seen for, in the vicinity is the knee joint. So you should also have seen for the knee popliteal nodes also. What is the name of the cutaneous tuberculosis? If like this patient, if I say it's a cutaneous tuberculosis, what is the name of that?
I'm not aware.
Lupus vulgaris.
Okay.
That's called a lupus vulgaris. Right. Should I, can you go further now? Yeah.
I think one important thing here, sir, when he contracted this taut muscles, what you have to mention whether the swelling became more prominent, less prominent, because you have not mentioned the plane of the swelling. Very important for us.
Yeah.
You said
the swelling remained same on the.
So what does it tell you? It's a vertically oval swelling, restricted mobility side to side, correct? And
Yes.
when the bones are contracted, you said restricted mobility, soft to firm. Skin is not pinchable. So I'm trying to know, is it from the skin or is it subcutaneous fixed to the skin? Very important.
Yes, sir. It is a subcutaneous swelling fixed to muscle or fascia of the muscle.
So soft to firm swelling, correct?
Yes, sir.
So you have to keep it in mind all these things and because anticipate some questions later when you give a diagnosis. Because you have to tell why it is soft when you give a final diagnosis. Why it is soft, why it is firm. Remember, the patient has undergone surgery. The patient has undergone surgery. The plane is in the subcutaneous plane. Something is pointing there. So, not hard in consistency. We are all trying to, putting some kind of a diagnosis which you have to entertain as a differential diagnosis. That is the reason. Okay. Because of the surgery. Skin is not pinchable. Skin not pinchable, do you think it is the tumor infiltrating the skin or is it due to previous surgery?
Sir, it is more likely to be due to previous surgery, sir.
Or infiltration?
It can be tumor infiltrating the skin, but more likely due to previous surgery.
So, probably I would have expected the answer that usually when the whatever subcutaneous tumors come to the skin, there will be first initially skin dimpling, then slowly ulceration. Some amount of blood, all that will start. Here is a situation already been incised. Already one incision has been given. So whatever is there, slowly it is invading the skin. All right. Not fluctuant, restricted mobility. Can you go to the next slide? You have to mention the plane of the swelling very carefully whenever you have a thigh swelling. Okay.
Okay.
No palpable pulses over the swelling. You need to say pulsations.
Okay, no pulse. Yes, right? No pulse.
So no
pulsation. Yes.
Distal pulses are normal. You also should mention, as I mentioned, dilated veins. Probably, if we see carefully the vein, we may be able to see also. Taylor, no? Taylor. So we may find some longitudinous vein. Anyway, that's important for you to see carefully. Okay. No sensory motor deficit. Deficit spelling is checked up. No palpable inguinal lymph node. What do you mean by no palpable inguinal? Be specific. No lymph nodes at all or no significant nodes? What do you mean by that?
No lymph nodes were palpable at all.
Previous surgery done, wound has healed by second infection, Taylor. So you can expect few nodes, but however, since we can't examine, so we have to believe whatever you say.
Yes.
Better to use the word no significant.
Significant. Yes.
What do you mean by the word significant here? For the drawing. To what size? See, agriculturists, filariasis, our coastal belt filariasis, recurrent infection, toenail. So up to what size you can allow? Somebody has a to what size? Maybe 1.5 to 2 centimeter also, beyond which you say
Significant.
size criteria, then consistency to be hard, restricted mobility, then becomes significant. Okay, right. So anyone else, sir? Externals, next, yes, sir.
Sorry, sir.
Anyone else? Ask question, please. Today's examiners.
Mukesh bhai, Akash bhai, few questions from your side, if possible.
Karthik, tell me the differential diagnosis. As in your slide on inspection, there is no any inguinal swelling. So let me the differential diagnosis of inguinal swelling. As in this patient, we are expecting palpable lymph node. Other
Lymph
swelling?
nodes, yes. Lymph node, palpable lymph nodes in inguinal swelling. Hernias can be hernia, saphena, varix.
So
Lymphadenopathy due to a recurrent infection or TB.
so how you will differentiate each? Some differentiate point are there for each diagnosis. So tell me the
Yes, sir.
differentiating point of each.
If there is lymphadenopathy, the swelling will be not reducible. There will be no pulsation, and the swelling will be firm in consistency. In hernia, the swelling is reducible and cough impulse is present. On saphena varix, cough impulse is present, and the swelling is reducible as well.
Okay. Okay, go ahead.
Based on history and my clinical examination, my provisional diagnosis is.
Karthik, just sorry, only one question. If your case has got significant nodes, what possibilities you would have thought? If your patient has got
Yes, sir.
say firm significant nodes 2 centimeter size, or some of them are hard, so what you would have thought?
As I'm suspecting soft tissue tumor, I would think of nodal metastasis.
That's what I wanted to know. So that would have added to one of the strong points for you in favor of your diagnosis of malignancy. Number one,
Malignancy.
malignancy means your case soft tissue. Second important thing is, in that, what are the subtypes which spread by lymphatics?
Yes, sir. There is epithelioid sarcoma, clear cell sarcoma, Ewing sarcoma. These are the most common ones having lymph node metastasis.
So quickly, you can remember as reference rhabdomyosarcoma, angiosarcoma, clear cell sarcoma, epithelioid sarcoma, synovial sarcoma. Some of these are common ones, which if they ask you this question, so that's the importance of the clinical examination of the inguinal nodes.
Yes, sir.
Yeah. Okay, now come to the diagnosis.
Yes, the based on clinical examination and history, the swelling is most probably soft tissue sarcoma of right thigh. On basis of 8th HSCC classification, it is T2N0M0 as the greatest dimension is 7 centimeter. Grading is not available yet. So if the tumor is grade 1, then it would be stage 1B, and if the grading if it is of grade 2 or 3, it would be stage 3A.
So one or two things for you. In your MS examination, you will not write all this if grade 1, grade 2 like that, because you are going to only say, when you are asked a provisional diagnosis, you don't have to even use the word probable. When you are writing a diagnosis, say soft tissue sarcoma, right thigh region. The only thing here is probably. You have to mention where, what is it? If they ask you, first diagnosis. Why do you say it's sarcoma?
The swelling is progressively increasing, and recently it is causing pain. So
Pain may not help you to that extent to make a diagnosis of sarcoma. I will take
okay,
it,
sir.
yes, progressive increase in the thigh is one of the sites, and progressive increase.
Yes, sir. And there is a history of trauma, and there is latent period.
No.
12 years.
That will not help you. So
Okay.
the only thing which helps you is the local region, one of the sites. Second thing is increase. And in your entire list of clinical examination, what may help you to give a diagnosis?
On making the muscle taut, the swelling is become less mobile. And
No, you never mentioned less prominent. Nowhere.
that's reduced mobility.
You only said restricted mobility.
Restricted mobility on making the muscle taut.
So it will not really seriously help you, because it's a chronic. Suppose I say somebody had large abscess there 12 years back, somebody has made a big incision, drained, pus drainage, layers are all open, some fibrosis. So all that might have caused into a foreign body reaction, which has happened now like that. So what answer you will give? Your answer is very long period. No patient was asymptomatic, correct?
Yes, sir.
How many years he was asymptomatic?
12 years.
Absolutely correct.
Hmm.
12 years patient was asymptomatic.
Asymptomatic, yes.
So that is the reason why probably this is a totally a new pathology. Probably.
Yeah.
This is how you, and having said that, this is, you said subcutaneous, because you said on muscle contraction, it is not reduced.
It is not becoming and not becoming more prominent.
What may be the tissue of origin now, if this question is asked?
Now, fibrous tissues are more like.
Fibrous tissue means?
As there was a trauma previously, and there is healing by secondary intention, there are more chances of having fibrous tissue at that time.
What is the tumor which you know? See, we can't have the clinical examination here, but from the skin itself can arise here in this area.
Yes, sir.
What is that? Was it more protruding out? Or
no,
was
sir.
it infiltrating? You said now you are able to lift or something, you were talking in the history.
Yes, sir. It is more likely to be from subcutaneous tissue rather than from the muscle.
Okay, I think.
And not a protuberance.
I
So
just wanted to rule out any dermatofibrosarcoma
protuberance. Yes.
Sir, somebody else can take over.
Hello, Dr. Karthik. This is Dr. Akash from Ahmedabad.
Yes.
You have mentioned in examination there is a mild tenderness present over the swelling.
Yes, sir.
So how it fits in with your diagnosis of soft tissue sarcoma?
The sarcomas is usually painless, but there might be outgrow tumor may outgrow the its blood supply and causing necrosis. So that might be the causating factor for tenderness.
Okay, continue.
Karthik, what are the various types of the sarcomas which can occur in this area?
Sir, other than soft tissue sarcoma, osteosarcomas are very common around the knee joint. Then the liposarcomas, which are most common in extremities. Then malignant fibrous histiocytomas,
Mhm.
which are also common in lower extremities.
Khanna sir, you are muted. Khanna sir, you are muted. Unmute.
Okay, this is the exophytic type of the tumor which is coming out.
Yes, sir.
You must keep a possibility of the dermatofibrosarcoma to protuberance also.
Protuberance.
Right. So it may be liposarcoma, it may be malignant fibrous histiocytoma, it may be rhabdomyosarcoma. Now, if the lymph nodes would have been palpable, then what you will think?
Then liposarcomas are less likely to be the cause if the
What
lymph nodes are
various sarcomas which can metastasize to the lymph nodes?
sir, epithelioid sarcoma, synovial sarcoma, rhabdomyosarcoma,
Hmm.
Ewing sarcoma, sir,
Angiosarcomas.
angiosarcoma.
Okay. Now you are saying it's the T2 and 0M0. T2 is, what is T2?
T2 is the greatest dimension of the swelling of more than 5 centimeters, but less than or equal to 10 centimeters.
Okay. Right. And what is the significance of the grade here?
Grade is the most important prognostic factor in case of soft tissue sarcoma, and the treatment may vary depending upon the grade of the tumor.
So here the TNM classification is usually called as
TNMG classification.
or GTNM classification.
GTNM classification. Yes, sir.
You know any other tumor where you have to add with the TNM something else for the classification? Any other tumors?
I'm not aware, sir.
Testicular tumors? You add the tumor markers in that.
Okay.
Along with the TNM classification, you add the tumor markers in that. Okay. So how you are going to proceed keeping a possibility. And then, in this patient, another possibility which you should keep in mind, it may be melanoma.
Yes.
Okay. Because it is a pigmented tumor is there. It is arising almost from the skin.
And
So if it is a melanoma, what type of the melanoma it will be?
Exophytic, sir.
No, it is exhibited,
Nodular type.
nodular variety.
Nodular. Yes, sir.
So what are the various types of melanomas?
No, I'm not aware of that.
Superficial spreading, nodular.
Ulcerative.
Okay. Okay, so go ahead with their investigation for this patient.
I would go for a plain X-ray of right thigh to check for any lesion of bone. As the cortex is intact, there is less likely to be any bone involvement. I would go for MRI.
Will be involved in this patient?
Sorry, sir?
Clinically, Clinically, do you think the bone will be involved in this patient? Clinically?
No, sir. No, sir. Clinically,
Okay,
there is no evidence. So
right.
then,
Yeah.
as I'm suspecting soft tissue sarcoma, I will go for MRI of the right thigh.
Right.
After that, I would go for USG guided core needle biopsy.
Tell the MRI findings.
A well-defined 47 by 67 size lesion is seen in right lower thigh and subcutaneous plane, appearing predominantly hypointense on T1 weighted images and hyperintense on T2 weighted instead images. It indents the adjoint muscle, however, no evidence of infiltration. Neurovascular bundle appears normal, hip joint normal, no evidence of bone invasion. Impression is well-defined lesion in medial subcutaneous plate pain of right lower thigh, possibility of sarcoma or neurogenic. On T2 weighted images, the
It is not involving any muscle.
no, sir, the muscle are compressed, but no muscle is involved, and intensity, the variegated intensity is present. We can appreciate the cystic area,
Yes.
and it is in very close
Whenever,
proximity.
whenever you see really, white, bright, when especially this type of lesions in MRI, that's how they usually give a diagnosis of neurogenic origin, especially peripheral nerve sheath tumors,
Tumor, yes, sir.
especially in the retroperitoneum and all, white, bright, very, very white, bright. Okay, please go ahead.
After MRI, I would like to go for USG guided core needle biopsy and subsequent immunohistochemistry of the biopsy specimen.
So from where you will do a biopsy if you have to do a core needle biopsy in this patient?
For representative area, so the solid part of the tumors.
So from which part of the tumor you will enter the needle?
I would go from the part which is closest to the skin to avoid tumor spreading.
Yeah, it is almost fixed to the skin. The reason I'm asking whether you go from the anterior side or will you go from the lateral side?
Anterior side. So there is literally the saphenous vein is very proximal to this vein.
Not for the saphenous vein as such, Whenever you have to do a biopsy in a case of a sarcoma, you should be in the center of the lesion. Always center of the lesion, because that portion has to be excised. When you are planning the definitive treatment, that has to be excised. So that is why you will go from the anterior part of that, pick up the solid part, and then do a biopsy.
And in this case, you should have said from the scar itself, because otherwise also we are going to excise this scar.
Yes.
Yes.
What are the precautions when you do an open biopsy?
When we are doing open biopsy, the scar, the incision should be in the same incision in which we are opting to operate in future. It should be in the subject, and it should be without creating any planes. Absolute hemostasis is to be achieved, and preferably no drain should be kept to avoid tumor spreading, and preferably by the same surgeon who is going to operate in future.
What is the size of the needle in a case of core needle biopsy?
In core needle biopsy, we use 14 to 16 gauge needles.
When you do FNAB, then how much is the size?
21 to 23 gauge.
FNAB. This you are telling about the FNAC.
FNSC, yes, sir.
Okay,
I'm not
asking
aware of FNAB.
18 to 20 gauge, you know?
80, yes,
And FNAC is 21 to 23 gauge.
23. Yes.
Okay. So biopsy has been done in this patient?
Yes, sir.
Good.
The core needle biopsy report the findings are suggestive of spindle cell tumor, possibility of fibrohistiocytic tumor, more likely.
You have not given the grade of the tumor?
No, sir. They are advising for excision biopsy and immunohistochemistry or tumor potential.
Okay. So what other investigation you are planning in this patient?
I would go for immunohistochemistry. And
Yeah, Karthik.
chest X-ray of the patient.
And just Karthik, only one important question. When you are pathologists are giving, apart from that, what you said, three important things they will give, because that is very important for sarcoma. What are those three things under microscopy? There are written there.
Yes, sir. For grade, the cellular differentiation, amount of necrosis, and the number of mitosis.
Very good. So you also remember as a TNM only, tumor differentiation. N is necrosis.
Number of necrosis
N is
and
mitosis.
mitosis.
And there's a scoring there. Necrosis 0, 1, 2, others are 1, 2, 3, 1, 2, 3, like that.
Yes, FNCLCC class.
Okay, please go ahead. Thank you.
Yes, sir.
Yes, so you are going
FNCLCC class.
metastatic workup in this patient.
Ideally, HRCT HRCT chest should be done, but we in our institute went for chest X-rays.
Okay.
And USG of abdomen and pelvis, which was unremarkable.
Abdomen for what?
To check for any liver metastasis.
Any biochemical profile you are going to do? Routine blood investigation we will do, sir. Biochemical.
Completely.
Will you do the liver function test?
Yes, sir.
Now, in the liver function test, you find that the alkaline phosphatase is raised. What does that mean?
Okay. Bone abnormalities, bone abnormal.
And one is the bony. Anything else? Raised alkaline phosphatase. Liver metastasis.
Yes.
So it can be either liver or it can be bone metastasis. So then further what you will do to differentiate whether it is the liver or it is the bone? Biochemical investigation.
LDH, sir?
The alkaline phosphatase, you can do the subtyping of whether it is a stable variety or whether it is a labile variety. In both, it is different. You know? And then you will do a serum calcium. If the serum calcium is raised, it is likely the bony metastasis. If serum bilirubin is raised, it is likely to the liver metastasis.
Liver metastasis.
Okay, all right. Okay, so what is your plan now? You have done all these things. There is no metastasis.
I will go for a wide local excision followed by radiotherapy.
What are the various types of excision in the sarcoma?
4 types of intralesional, marginal, wide local, and the compartmental resection.
Okay. So in this patient, what you are planning?
In this patient, I would go for wide local excision with margins of 1 to 2 centimeter, followed by radiotherapy.
So will you be able to cover it primarily?
Mm,
Will you be able
Yes,
to
sir.
wound primarily?
Mm, Most likely, sir. If not, then flap of some.
So from where you would take the flap?
I'm not sure, sir.
Anna, sir, you're muted.
There can be various types of rotational flaps may be there, or even sometimes is required the cross-leg flap may be used, or a microvascular flap can be used. You know? Right. Okay. What precaution you will take when you are doing the wide excision here?
Mm.
What vital structures will come?
Great saphenous vein, sir.
Yes.
So I would only cover the exercise the fascia over the great saphenous vein for the qualitative margins, sir, rather than quantitative margins.
So how the sacrifice of the great saphenous vein will cause any problem?
Yes, sir. Limb edema, sir, distal limb edema, sir. If,
Sometimes, you know, it is sometimes that you can. But you have to take the care because it's the same place where the popliteal vessels will be coming. Okay, it is crossing the Hunter's Canal at that point.
yes, sir, at the junction of middle and lower third.
Yes, you have to be careful about that also there. No? Right. Dr. Shina, can we close it? Dr.
Yes, sir. Khanna, sir, you are muted
Yes, sir.
again. Sir, you are muted.
It is automatically getting muted, Janet.
Rajgopal, sir, are you there? Akash bhai, Mukesh bhai, any questions from your side, or shall we close the discussion? Karthik, do you want to ask any question to the teachers?
No.
So well done. I think you can unshare your slide. We will go for the next case. Dr. Bhaskaran, are you there? Please unmute yourself and share your screen, introduce yourself, and continue with the history and examination. Share your screen. Well done, Karthik.
Good evening, sir. Am I audible, sir?
Yes, you are audible. Please make it full screen. You can go to slideshow. You can go to slideshow. From beginning. Make full screen. Yes. Start. Yes, very good. All the best.
Good evening, sir. I am myself Dr. Bhaskaran, final year postgraduate. My guide is Dr. K. Saravanan, sir, head of the department, Dr. Syed Ibrahim, sir, from Madurai Medical College. A case of swelling over the right parotid region. Chief complaints: a 30-year-old female patient came with, who is a home worker, came with the chief complaints of swelling below the right ear for past 2 years. History of presenting illness: The patient was apparently normal 2 years back, after which she noticed a swelling below the right ear, which was insidious in onset. It was initially small in size, gradually progressed to present size. The swelling is not associated with pain. No history of increase in the size of the swelling while eating. No history of pain while chewing. No history of pain in the ear. No history of restriction of mouth opening. No history of deviation of angle of mouth. No history of difficulty in closing eyes. No history of drooling of saliva from mouth. No history of spillage of food from the mouth while eating. No history of sudden increase in size of swelling. No history of loss of weight or loss of appetite. No history of any other swelling on the opposite side of the face and neck. Past history, not a known case of hypertension, diabetes mellitus, tuberculosis, asthma, and epilepsy. No history of previous surgery. No history of any drug intake. Family history, no history of similar complaints in the family members. Menstrual history, nil significant. Marital history, nil significant. Personal history, patient consumed a mixed diet. Bowel and bladder habits are regular and normal. Tobacco chewer for past 5 years. Not a known smoker or alcoholic. Summary, a 30 years old lady came with a painless progressive swelling below the right ear since 2 years with a history of tobacco chewing for past 5 years. Shall I continue, sir? Sir, shall I continue, sir?
Go to first slide, history. Rajgopal sir, Khanna sir, please take over.
Yeah, so Bhaskaran, can you hear me?
Yes, sir.
Yeah, just can you go to the next slide? Yeah, so it would be nice if you were to put a picture only now only. So it's all right, no problem. So 2 years back, normal, and then she noticed the swelling, which was into small and progressed to the present size. Again, the question that comes is how much small it was and how much now, because we don't have any idea. Okay, so we'd like to, because if there's a picture is there, we would have had a very clear idea. Like last case, it was peanut size to 7 centimeter. So like, can I ask, roughly what was that before and what is it now?
Initially, patient told approximately 2 to 3 centimeters. Now it's around 5 cross 6 centimeters.
So that's what it gives, more or less rapid growth or slow growth?
Slow growth, sir. No rapid increase in size, sir.
So it is obviously a slow progressive swelling. Again, coming back to the same, like last, whatever thigh swelling, there it was 7 months, and in your case, it is 2 years. And swelling, progress, you have mentioned, right? Okay. The thing is, in the last 2 years, whether she has also noticed any swelling is not associated with the pain, like what pain you get?
In case of developing a malignancy, rapid increase in size and also pain associated with the swelling also present, sir. To rule out the malignancy of the pain, and also if the swelling is a short duration, we can rule out sialadenitis, sir. In this case, patient have pain over the swelling, sir.
What is the difference between a sialadenitis and sialactasis?
Sialadenitis is inflammation of the gland, sir. Sialactasis is a dilatation of the parotid duct, sir.
Duct, only duct. Sialactasis. Bronchiectasis. So why I ask this question? Because you said
saliva within the duct.
No. Sialactasis is, what is the cause of sialactasis?
Ductal obstruction due to calculus.
No. That is that you get sialadenitis. You will not get that. Usually they are all congenital, like a bronchiectasis. Bronchiectasis is different, right? So it's a congenital sialactasis. Okay. So they will have a childhood, recurrent infections, recurrent common. Okay. Sialactasis. So this is a sialadenitis if you have a stone there. Right. Swelling is not associated with the pain. So the second important question that you have to ask is, you have written the no history of intra swelling while eating food. Is it common in parotid swelling?
In elderly patients, it may be present, sir. In poor oral hygiene regated patient, in ICU patients also.
ICU patient, your patient is in ICU? No.
No, sir. No, sir. In my patient, there is no history.
Day to day, you don't get this in a parotid, but you get in submandibular gland. Why is that?
Anti-dependent drainage of salivary ducts, submandibular salivary ducts.
Anything else?
And
Contents are more thicker.
Contents are more thicker and viscid.
And rich in calcium contents. Okay, so in other words, you get a more calculus disease in the submandibular salivary gland, right?
Okay. Yes.
And you don't get stone in the parotid, right? So the typical history of enlargement is classical of a submandibular situation. Okay. Hello.
Yes, sir.
Any other next slide? What did you write in the next slide? This you already mentioned, no? Pain while chewing. Why pain in the ear?
Due to referred pain due to involvement of auriculotemporal nerve by the swellings.
What way parotid is related to auriculotemporal nerve as far as this statement what you made just now?
Auriculotemporal nerve close to the upper pole of the parotid gland, sir.
How does it enter there? Relation to the neck of the mandible. Okay, neck there. Large tumors, parotid. Okay, then only you will get that. Otherwise, you won't. So all this, every question which you have asked, they will ask you these questions. Okay, so all this, no, difficulty in ruling, spillage, all that thing can probably a short case, one sentence you can mention. It is examiners will ask you what are the signs. Then you can mention. No history suggestive of facial nerve paralysis. That's all right because you have done those tests. Short case. This is not a huge case. But anyway, if in your institute they have throttle, you can continue. There is no problem about that. Whenever you have a swelling of in the region of parotid for 2 years duration below the ear lobule, whatever you said. Don't you think there is some benign disease? What benign disease you can get there other than the parotid? Other than the parotid swellings, what other swellings you get in the parotid region?
Preauricular lymph nodes, sir.
Preauricular lymph node? Yes, possible, but 2 years duration, less likely. However, all right. Anything else?
Warthin's tumor, other?
No. Other than the
parotid.
Other than. Always think of a first start from even a dermoid. You can get a dermoid cyst also. Okay. You heard of preauricular dermoid cyst?
I didn't hear that. I'm not aware of this.
Oh, okay. So, yeah, sorry about that because sometimes you get trapped in simple questions in the MS exam. Preauricular, postauricular dermoids occurred due failure of the fusion of this pinna. Pinna is formed by 6 tubercles. One of them fail, you get those ectodermal elements getting trapped and you get that dermoid cyst. Okay. Dermoid cyst, lymphatic cysts, vascular malformations, even a lipoma, neural tumor, lymph node metastasis, are some of the DDs for the swelling in the parotid region. So just keep it in mind. This is a list. Okay. Sir. So today's other people can also ask, sir, if anyone is.
Dr. Mukesh Bhai, Akash Bhai. Khanna sir, are you there?
What are the causes of bilateral parotid swelling?
Warthin's tumor, mumps, and
What is the
Lymphoma.
commonest cause of the bilateral parotid swelling?
Commonest cause is mumps.
Mumps is not so common, is it?
Jorgens, silenitis.
Patient is in the ICU.
Oh, silenitis.
Yes. Bilateral sialoadenitis. The patients who are in has got the poor oral hygiene, and oral cleaning is not done, patient in the ICU, they are more likely to have then mumps may be there. Okay, what other tumors can be bilateral?
Martin's tumor,
Mhm.
lymphoma,
Yes.
and adenoid cystic carcinoma.
Okay.
Mm.
What is parotid region?
Parotid region bounded by anteriorly by the ramus of mandible, posteriorly by the mastoid process, inferiorly by the posterior belly of digastric, and superiorly by the zygomatic process.
Now, out of all these branches of the facial nerve which is there, which one is the most important branch?
Zygomatic branch.
Why the zygomatic branch?
Due to injury of zygomatic branch, it will cause exposure keratitis.
Mhm. So what can happen because of exposure keratitis?
Corneal blindness.
Yes, it can lead to ulceration there, corneal ulceration may be there, and it may be the patient will become blind after that. Okay. Go to your next slide. Next slide. Does the parotid tumor run in families? Or
Not so common.
parotid swellings?
Not common.
Any parotid swelling which may run in families?
No. Sir.
Sjogren syndrome and all those types of the collagen disorders. They can run in families. Okay. Go to the examination.
Physical examination. Patient was examined in sitting position in a well-lit room after taking consent. Patient well built and nourished. No pallor, no icterus, no cyanosis, no clubbing, no generalized lymphadenopathy, no pedal edema. Vital signs: blood pressure 130/80 millimeter of mercury, pulse 76 beats per minute, normal volume, regular rhythm, respiratory rate 16 cycles per minute, temperature afebrile. Local examination. Inspection on the right side, a swelling of size 6 cross 5 centimeter approximately, solitary hemispherical inside, hemispherical swelling in the right parotid region, lifting the ear lobule, extending superiorly 4 centimeter from the zygomatic arch, inferiorly 2 centimeter from the angle of mandible, anterior border 7 centimeter from the angle of mouth, posterior border 1 centimeter from the anterior border of sternocleidomastoid muscle. Skin over the swelling appears normal, surface appears smooth, well-defined borders. Position of the right ear lobule appears to be displaced slightly upwards. Retromandibular groove obliterated. Facial symmetry appears to be normal. No other swelling noted in the neck. Left parotid region appears to be normal. This is the image of the patient, sir. Palpation, no local rise in temperature, no tenderness. Inspectory findings of swelling size, shape, and extent of confirmed. Firm in consistency, mobile in both horizontal and vertical direction. Margins are well defined, irregular and rounded. Skin over the swelling pinchable. Swelling could not be moved above the zygomatic arch. Swelling not fixed to underlying masseter muscle. On bidigital palpation, deep lobe of gland not palpable. Parotid duct palpation normal. Left parotid region normal. Other salivary gland normal. No enlarged or palpable cervical lymph nodes. Oral cavity examination. mouth opening adequate, oral hygiene maintained, uvula in center, no medial displacement of tonsil, parotid duct to opening normal, no disturb, lips and gums normal, palate normal, jaw movements normal. Facial nerve examination, sensory taste sensation normal, motor, forehead wrinkles are present, able to raise the both eyebrows, able to close both eyes, able to blow out both the cheeks, nasolabial folds on both sides is prominent, angle of mouth is not deviated, no drooling of saliva, able to clench the teeth, facial symmetry is maintained. Systemic examination, cardiovascular system, S1, S2 heard, no murmur, respiratory system, normal vesicular blood sounds heard, no added sounds, perabdomen soft, non tender, no organomegaly, central nervous system, no focal neurological deficit. Summary: a 30-year-old female came with painless progressive swelling below the right ear since 2 years, with a history of tobacco chewing for past 5 years. On examination, a swelling of say 6 cross 5 centimeter approximately, solitary hemispherical swelling in the right parotid region, firm in consistency, retromandibular groove, obliterative.
How you done the bi-digital examination in your patient?
By using index finger inside the mouth, just palpating in front of the tonsil, and thumb over the cheek, and rolling against upper second molar tooth, and palpating the parotid ducts.
So you are looking for the parotid duct or parotid deep lobe of the parotid? If you are doing the
Parotid.
bi-digital examination for, there is a difference between the bi-digital doing for the parotid duct and doing for the deep lobe.
Yes, by digital.
You have mixed up both the things. So tell how will you palpate the parotid duct and tell how will you palpate the deep lobe of the parotid.
Deep lobe of parotid can be palpated by bimanual method, by using one finger in one finger of one hand.
Your hand inside, again a bi-digital.
Okay.
It's not the bi-manual, it is the bi-digital again. So where are you going to put your fingers?
One finger inside the mouth, just in front of the tonsil, and other fingers outside the mouth, just over the swellings.
Not over the swelling. You have been repeatedly saying something, and even in the summary you have told about that sign which is there. It is the retromandibular groove. Okay, so you are going to put your finger in the retromandibular groove. Okay, not on the cheek and not on the swelling, but over the retromandibular groove you are going to put. That is for the deep lobe of the parotid. And for the parotid duct?
Parotid duct, asking the patient to clench her teeth, and then palpating the parotid duct by rolling the parotid duct by using fingers over the masseter muscles.
Where?
Landmark is imaginary line joining the tragus and midpoint between the ala of nose and angle of nose.
Which
middle
part?
Middle 1/3.
Medial 1/3 or middle 1/3?
Middle, sir.
Middle 1/3.
Middle 1/3.
So middle 1/3 of that, and then you roll there on the clinched teeth.
Yes.
Right. In your oral examination, you did not tell about the parotid opening here. Have you mentioned that?
No, sir.
The oral examination?
Parotid duct opening normal, sir. No discharge.
Normal, right. Where did you see for that?
Opposite to the buccal surface of cheek, opposite to the crown of second upper molar tooth.
Okay. Right. What are the various nerves which come in relation to the parotid?
facial nerve, the substance of the gland, and pole, near the upper pole, auriculotemporal nerve, and greater auricular nerve near the lower poles. And facial nerve it's in branches also related to it.
And what is Petty's plane?
Faciovenous plane of Patty is formed by facial nerve and retromandibular veins, which divides the gland into superficial and deep lobes.
There are only two structures in that, or three structures in the facial plane?
External carotid artery also passed within the planes.
Which is superficial, which is deep?
External carotid artery is deeper, sir, and then retromandibular vein present, sir. Superficial is facial nerves.
Okay. Okay, Dr. Shenoy.
Bhaskaran, only one. Just show that picture once. Just wanted to ask you one simple question. You mentioned what is that? Cannot be moved above the zygomatic arch. Do you think it's possible here?
No, sir.
Then, do you think it's important here?
No, sir.
Looking at that picture, what do you think the location of the swelling?
It's rises near the lower pole of the soul.
So it's almost toward the angle of the mandible going into the neck region. Okay, number one. Hardly anything. You said the ear lobule raised. Yes, we have to believe slightly. You can see there. Very, very. Because if you were to have another picture comparison would have done. And you said, what about the intrinsic mobility? How far you were able to move this swelling?
It can move slightly in both the horizontal and the vertical directions.
Did you contract the masseter?
Yes, sir.
Did you contract the sternomastoid muscle?
Yes, sir. After ask the patient to clench his teeth, clench her teeth, then move, then swelling is moved in both the directions, sir.
Do you suspect any infiltration to the masseter?
No, sir. Not fixed to underlying structures, sir.
Now, why did I ask question related to sternomastoid? I have no doubt that it is, but why did I ask that question related to sternomastoid? Okay.
It can be to
yes,
level 2.
Yes.
Level 2 notes.
Yeah, this is a very important small finding. If this swelling were to be a little below, tail of the parotid. Where is the tail of the parotid located?
Near the angle of mandible.
It's almost
near the angle.
It's almost in the neck. Neck means yes. What you write. So, if you contract the sternomastoid, what is the difference between parotid swelling versus lymph node swelling?
Parotid swelling, it's not its mobility. It's not related to sternocleidomastoid.
Its size will not be affected. In fact, it will become more prominent, whereas the lymph node swelling will become
more prominent.
No. Diminished. Diminished.
Lymph nodes are deep to the
nodes, deep to the sternocleidomastoid.
This is the way in which you differentiate lower pole parotid tumors. Okay, lower pole.
Okay.
All right, which are sometimes you get in the very close, little below there. One look also will tell what is the consistency you mentioned.
Firm in consistency.
Not cystic. Did you try any time badges in this patient? Densely cystic swelling will feel firm. Why densely cystic swelling will be firm in the parotid swellings?
It is encapsulated.
No, that is not like that. What is the structure which is covering the parotid gland?
Parotid fascia covering the.
Parotid fascia is a tough fascia, correct? Yeah, parotid fascia is a tough fascia. Mumps, you get severe pain, correct? Why do you get pain in mumps?
Due to parotid fascia.
No doubt it is slowly enlarging. So sometimes in a thyroid nodule, sometimes in a parotid swelling like this, they are all paradoxal. Paradox means densely cystic swelling even may feel firm or even hard. You understand? So try to hold the swelling, and when you are moving, put your index finger and check for any centrally yielding. Yielding means some kind of a softening. It can also happen in a part of a adenolymphoma. This has been asked to you sometime. No? Cystic swell, what this tumor, or a cystic degeneration also in a mixed tumors, pleomorphic, and it doesn't look like whatever. That's also a few questions from my side. Thank you.
Khanna sir, are you there? Mukesh bhai? Yes sir, Khanna sir.
So what is your diagnosis here?
A case of right benign parotid swelling, most probably pleomorphic adenoma without facial nerve, deep lobe, and cervical lymph node involvement.
Pleomorphic adenoma is a pathological term.
Surface,
So what you will like to call it as a clinical terms. Though we always say it is a pleomorphic adenoma, but that is a pathological entity, isn't it? So what you call it as a clinical entity? It's called a mixed parotid tumor, right? Okay. We very regularly say it is a pleomorphic adenoma, but that is only after the histology or the FNAC or it has come. Okay. So why you say it is a parotid? First tell about that, and then why you say it is a pleomorphic adenoma.
It's located in the parotid region, sir.
Okay.
It's a benign swelling, sir, based on a history and examination.
Okay.
And most common tumor in the parotid region with benign swelling is a pleomorphic adenoma, sir, or mixed parotid tumors.
Okay, agreed here. What is the chance of having the malignancy in parotid tumor?
In parotid tumors, 80% of tumors are benign, sir, 20% malignant.
And in case of submandibular tumors?
Submandibular tumors, 50% of benign, 50% are malignant, sir.
And minor salivary glands?
It's around 10, 5% of benign and 95% are malignant.
Yeah, majority are the malignant one there. Okay. And okay, so how will you proceed with the diagnosis?
I will investigate these patients, sir. Routine blood investigations and initial investigation imaging is ultrasound, sir.
Diagnosis, no?
Sir?
First, you have to make a diagnosis. Whenever you're going for the investigations, routine investigations are the last part. Okay. When you're going to treat that patient. So always first you have to make the diagnosis.
Okay.
Okay. So for diagnosis, what are you going to do?
Ultrasound local parts, sir, to confirm the parotid swelling and its size and extent, and then CT, and then MRI if needed, sir, and then invasive investigation like FNAC.
So in all cases of parotid tumor, you do the CT scan or MRI scan?
No, sir. If swelling is deep lobe involvement or involvement of temporomandibular joint or pterygoid plates, we can use CT scans.
And what are the other indications of doing the CT scan apart from this?
Skull-based involvement can be seen in CT scans.
Yes, if there is a facial nerve involvement is there, then also you do a CT scan. If it's a recurrent tumor is there, then you will do the CT scan, but not in the case like this, which is a primary tumor, where you are not having any suspicion of the deep lobe or the facial nerve. Okay, and what about the FNAC? Is it always must to carry out the FNAC or not?
Yes, sir. To rule out the malignancy and to confirm it's a benign swelling.
Is it 100% that you will have to do that FNSC, or it's a debatable thing?
It's a debatable one.
Slightly debate is there in that, you know? Because the minimal surgery which is done, usually which is said for the parotid tumor, is that you are going to do a superficial parotidectomy. But now there is a concept also for the adequate parotidectomy. You know what is adequate parotidectomy?
Not aware of it.
You know, when you are doing the superficial parotidectomy, there is a chance of damaging the facial nerve is there.
Okay.
So to prevent the facial nerve injury, where in this type of the patients where it is a very superficial protruding tumor is there, you can go with a margin of that rather than going for the complete superficial parotidectomy to avoid the injury to the facial nerve. You know, that is called an adequate parotidectomy. So in FNAC, what will be the findings?
It's features suggestive or suspicious of malignancy.
Suspicious of malignancy here.
Um,
What are the reasons for that? Just read the biopsy report.
cellular smears study shows seeds and clusters of ductal epithelial cells and myoepithelial cells in a mixed background. In focal areas, epithelial cells in the clusters show nuclear atypias. It's due to nuclear atypia, they suspect malignancy. Sir.
So because the nuclear ATPI. Okay. Right. Now next in your patient now, where there is suspicion of malignancy is there, what you are going to do now?
I will do CT, sir.
You do the CT scan. Has it been done in this patient?
Yes, sir. Done, sir.
Okay. Tell about that.
Minimal involvement of deep lobe also is there, sir.
Okay. Right. And lymph nodes in the neck?
No palpable and clinic notes.
No, CT-wise. CT-wise notes are there?
No notes. Sir.
No notes. Okay. Facial nerve involvement?
No facial nerve involvement, sir, in CT also.
Can they tell on CT scan the facial nerve involvement? Difficult, eh? It is difficult to tell on the CT scan. You may have to go for the MRI scan now for that. Okay. All right. Then next, what investigation has been done?
Then FNEC.
FNAC already done, no?
And routine investigation to assess the patient.
Okay. So has the patient been operated?
It's operated, sir. Biopsy report awaited, sir.
What operation was done?
It's done total conservative parotidectomy, sir.
Okay, good. What is the meaning of total conservative parotidectomy?
It's a removal of both the superficial and deep loop with the conserving facial nerves.
Right. Now, how do you make an incision for the parotidectomy?
Lacy incision, sir. First,
you drape your patient?
yes.
How the draping is done?
Draping should be
What
done.
First, tell the position of the patient.
Supine with the head tilted to opposite side with the reverse tenderloin position up to 30 degrees. Sir.
Okay.
And then
anything else?
neck extended.
Neck extended. So how will you keep the neck extended?
Shoulder roll should be kept.
Shoulder roll and?
Head ring should be kept.
Huh?
Head rings.
What's that?
Head ring, sir.
Ring. Head ring. Okay. Donut. Right? So you have to put a donut underneath the scalp. Right? Then how do you drape?
Draping should be exposed from the angle of mouth and lateral canthus,
Mhm.
outer canthus, and posteriorly up to exposing sternocleidomastoid muscle mastoid process.
What is this technique called as?
Oxley technique.
Hopsley technique, yeah. Okay. So now make the incision.
Yes. Incision preauricular part and mastoid part and cervical parts.
Good.
Incision made as close to the tragus between preauricular part and around the earlobe, and then curved downwards and in front of the sternocleidomastoid.
So how much downwards in relation to the margin of the mandible?
2 centimeters
Why?
to avoid injury to marginal mandible.
Good. Yes. Okay. Then
And then flap raised. Anterior flap should be raised up to the anterior border of glands, the parotid gland. And then posterior flap raised and sternocleidomastoid muscle retracted along the anterior border of sternocleidomastoid, avascular plane created, and then gland retracted and facial nerve raised from
which
the landmarks of facial.
other important muscle come in that area to identify the facial nerve?
Posterior belly of digastric muscles.
Right.
Just superior to posterior belly of digastric facial nerve presence.
Right. Okay. So which point is that? What is the name of that point?
Tragal point is it's also a landmark, which is a antero-inferior part of cartilaginous scalene of the external artery meatus.
What is Conley's point?
Conley's point is cartilaginous, cartilaginous and bony canal of the external artery meatus.
Okay. What are the other pointers for the facial nerve?
And tympanomastoid sutures, deep to tympanomastoid suture. Lateral to styloid process.
Yes. Can you trace it from the anterior side?
Yes, in a retrograde manner, you can trace it from the branches to trunks.
What is the name of that technique?
It's a Hamilton Bailey technique, sir.
Hamilton Bailey technique. Good. Okay. So you have, for doing a total conservative pedrectomy, what precautions? How do you remove the deep lobe?
After removing superficial lobe, branches are dissected separately, and nylon slings are put over the branches and retracted the nerves, and then deep lobe dissected and can be removed.
So if there is a big deep lobe is there, then how will you remove that?
Can be removed from the after doing mandibulectomy.
No, you may have to sometimes chop the parotid, make the small pieces of that and bring it out between the branches of the nerve share.
Okay.
Okay, good. Right. So you have done the, if you damage the facial nerve and you recognize at that time, what you will do?
It can be primary suturing can be done, sir, using 80 coding.
When can you do a primary suturing?
There is no say if there is no segment loss, we can do primary suturing.
No segment or less than 1 to 2 centimeters. And you can mobilize the facial nerve and do a primary suturing of that. If you are not able to do the primary suturing, then what can you do?
Cable graft can be used, sir, using great auricular nerve or sural nerve.
Okay. If there is facial nerve injury, what is that classification called as? You know about that? Injury of the facial nerve. What is the name of that classification?
Don't.
Is starts with H. I'm also forgetting that. Yeah. Dr. Shinoy, do you remember? So there's a classification of the facial nerve injuries there. Right. So you detect it post-operatively. Then what are you going to do?
Steroids can be used, sir. If there is a temporary facial weakness, it can be improved. Uh, uh, it can be improved within 6 weeks, sir.
Mhm.
If it is a permanent facial nerve palsy,
Mhm.
then we can do muscle transfer procedures.
What are the various muscle transfers which can be done?
For orbicularis oculi, we can transfer temporalis flap, sir.
Right.
And orbicularis oris, we can transfer masseter muscle transfer.
Mhm. Mhm. Okay. What are the other complications which can occur?
Price syndrome, parotid fistula, seroma wound infections are common, sir.
Mhm. Okay, this facial nerve damage, the classification, the House-Brackman, you know. Okay, House-Brackman classification is there. By that you can identify that whether you have done, it's just a neuroparesis is there or neurotomesis is there, depending on that. Okay. So how do you treat the Freight syndrome?
Antiperspirant, sir. Ammonium chloride,
Yes.
botulinum toxin can be used.
Right.
And tympanic neurotomy can be.
Yes. At the time of the surgery, how can you prevent? What precautions you can take?
Thick plaque can be prevented.
Yes.
Can be artificial membranes between the parotid bed and skin flaps.
And even the dermal fat can be put in that area, no? To avoid the connection between the skin and the underlying structures. Good. Well read. Yeah. Doctor. So what is the plan in this patient now? The biopsy report has come?
If it comes as a malignancy, then we can proceed with the radiotherapy. Adjuvant radiotherapy.
Still you are waiting for the biopsy report?
Yes, sir. Biopsy report awaited.
Okay. So what are the various malignant tumors of the parotid?
Mucoepidermoid carcinoma, acinic cell carcinoma, adenoid cystic carcinoma, and then epidermoid carcinoma, squamous cell carcinoma, and sebaceous carcinoma.
What is the characteristic of the adenoid cystic carcinoma?
Sir, what? Sorry, sir.
What is the characteristic of adenoid cystic carcinoma?
It's a perineural spread is a characteristic.
Good. Dr. Shinoy is there or anybody else?
I think he left, sir, for some work. Just 5 minutes back, he left.
If anybody else wants to ask any question?
Dr. Mukesh Bhai, are you there?
Yes, sir.
You can
Yes,
ask.
sir.
Yes.
Bhaskaran, tell me some criteria. As a benign condition, converted to a malignant condition.
It's a rapid increase in near slow growing tumors, sir. And then
Okay.
Pain in the swelling, so pain over the swelling.
Okay.
And then facial nerve involvement, sir.
Okay.
And then lymph nodes are enlarged.
Okay.
On trismus, development of trismus.
Okay.
Any other examiners? Dr. Kiritbhai, are you there?
Yes, sir.
Yeah. Any question from your side?
In between, there was some problem with my audio.
Okay,
So
okay.
I just wanted to know whether parotid fistula has been discussed or not. Management of parotid fistula.
Dr. Bhaskaran, you can continue with the answer.
Sir, no, sir, not discussed.
No, you can answer the question.
Yeah, please,
How
you
you
can
manage?
answer.
Can be. I'm not sure of the treatments.
Dr. Kiritbhai, you can reply. Hello. I think he has lost connection. Any other examiners would like to ask any question?
Bhaskaran, most common neoplasm of salivary gland in the children.
Sorry, sir.
Most common.
Most common salivary gland tumor.
Yeah. In pediatric patient.
Pleomorphic adenomas.
And malignant.
Mucoepidermoid carcinomas.
There is a percentage of 2 everywhere. Do you remember? 2% are benign, 2% false.
Not sure, sir.
Okay. So Khanna sir, I think he has answered very correct, very nicely.
Very well read. Yeah, very well read.
Very well read. And totally the different questions were answered as far as parotid is concerned because of his case selection and discussion. Any comments from your side, sir?
No, I think he has done very good. Yeah.
Yes, very good, very good. Very well appreciated. Thank you, sir. Thank you. So should we call it a day?
Yes, please.
Dr.
Yeah.
Kanagwal sir is in flight, so I'll be doing his job of just finishing. Thank you very much, Bhaskaran. You did really well, both the candidates. Thank you, Khanna sir. Thank you, Dr. Mukesh bhai. Dr. Rajgopal sir has left. Dr. Kirit bhai, thank you for joining from your busy schedule. And we'll meet next year now in 2024.
Okay. Happy New Year.
Happy New Year, everybody. Good night.
Thank you. Good night.